partnership with the Department of Social Welfare, Government of Nagaland. On today's panel, we have 7 distinguished panelists who will be bringing to the discussion their perspectives on this subject from their varied areas of expertise. So it's so wonderful to see so many familiar faces and some new young faces also. We have Dr. Atul Ambekar. Welcome, Dr. Ambekar. Mr. Keto Angami, Ms. Santina Ayer, Mr. Abu Mere, Nitze Meyer, Dr. Bernice De Witse, and Mr. Wango Langsim. My name is Tushi, and I'll be moderating this discussion today to identify priorities and recommend effective solutions in the context of substance use in Nagaland. So today we hope to be looking into a few specific areas, starting with the state-specific scenario of substance use. So our panelists will present an overview from a couple of different angles, primarily on the emerging trends and patterns of substance use in Nagaland. And for this, we will be drawing from the findings of the National Survey on the extent and pattern of substance use in India, which is commissioned by the Ministry of Social Justice and Empowerment. And we'll also be having inputs from the community's perspective on existing trends and patterns of substance use. So we feel that this will be an opportunity to share the areas addressed by existing programs under various departments in the state, and also to identify priorities that we can take up jointly. And we are looking forward to also hearing some updated information about perhaps the entry of new drugs in the market today and the implications of these new drugs and substances in the market. We will also be looking at specific subpopulations or vulnerable populations. Some of our esteemed panelists will also examine possible strategies to address adolescent populations, women who use drugs, and other key populations or at-risk populations who are vulnerable to substance use. And perhaps we will also quickly look at areas that require attention beyond the specific problems associated with substance use, beyond the traditional program. And we will also get some very important inputs on the role of civil society, whether it's CSOs or NGOs or faith-based organizations or community-based organizations, like what has been the response to substance use. And the panelists will probably will help us understand how communities of people who use drugs or alcohol, their families and civil society can respond effectively. To start us off, we want to begin today's discussion with a keynote address by Mr. Temjen Toy, who is the Chief Secretary of the Government of Nagaland.
A very good morning to all of you. At the outset, I would like to thank Kripa Foundation, led by Mr. Abu Mere, for organizing this consultation on substance abuse in Nagaland and the way forward. My apologies, I would have very much liked to be part of the consultation, maybe not as an active participant, but as a listener. But then I'm unable to do so, but I would like to request Abu to brief me on the outcome of this consultation, which I'm sure and I'm confident that a lot of new strategies on the way forward can be arrived at. When we talk of substance abuse in Nagaland, we've had it for over decades now. The problem is still very much alive in Nagaland, be it alcohol or drugs and other chemical derivatives. And efforts have been made throughout the years on tackling this problem. Many lives have been lost, and it is our bounden duty to ensure that more lives are not lost, and in fact we are able to wipe out this problem from the face of Nagaland. Like I said, efforts are being made, and one that quickly comes to mind is the efforts of a group of young people in Mon and supported by civil societies, NGOs and the church on how they have actually taken on the fight, and their efforts have paid off very well, in the sense that both demand as well as supply has fallen down considerably. And this kind of efforts need to be made across the state. And as years go by, with changing times, we need to adapt. We need to take on new strategies in order to deal with this problem. I am extremely happy that in our panel we have renowned names. Professor Dr. Atul Ambedkar, thank you very much for your time, and I'm sure your inputs will go a long way in shaping the strategy and the efforts that are put in Nagaland. And other panelists, senior officers, Nietzsche and others who have been involved in this field for quite many years now, thank you for your time and for your concern on this issue that confronts us in Nagaland. We are in the midst of the COVID pandemic, and as elsewhere all over the world, the focus of the state government has been mainly on controlling and the spread of this coronavirus. But in a way, it has also helped us in our addressing the problem of substance abuse, in that I have got reports of many drug users, who could not be reached. Now, because of the lockdown and other restrictions, they are not able to have access to their drugs of choice, and they are coming forward for registering themselves for the oral substitution therapy. So these are opportunities, these are advantages that we should utilize, and I'm sure through this consultation we will be able to come out with good strategies. Like I said, changing times, changing strategies, and a multi-pronged address to this problem, be it the government, be it the civil societies, the various NGOs who are working tirelessly, the faith-based organizations, and so on and so forth. Now, we find that the faith-based organizations also have a key role to play in this. Apart from, the scriptures, it is important that life skills and the realities of today's problems are addressed, so that our young people are kept within reasonable limits. And towards these efforts, I can only wish you all the best. Nagaland, we have our own substance abuse policy, which was adapted, if I'm not mistaken, in 2016. I really do not know the effectiveness of this, but then we need to implement this, and all the multiple partners, the NGOs, the various departments, we need to have a look at this policy and implement it, and along the way, if necessary, make the required amendments. So with these few words, I would like to thank the Kripa Foundation again for organizing this consultation, and my thanks to all the panelists, and I look forward to revival in our efforts towards fighting substance abuse in Nagaland, so that we all work together towards a better and brighter Nagaland. Thank you very much.
We really thank Mr. Tanjun Toy, the Chief Secretary, for his inspiring keynote address. And on that note, shall we proceed to meeting our panelists and getting to know them better and directly hear from them? So we request each of our panelists to make their opening remarks, for which 5 minutes each have been allotted. Um, we will start with Dr. Atul. Dr. Atul Ambekar is a professor at the National Drug Dependence Treatment Center in AIIMS. He is a member of many expert bodies, including the UN Strategic Advisory Group on Injecting Drug Use and the WHO Expert Advisory Panel on Drug Dependence. He has authored a number of research papers, practice guidelines, training manuals, and most relevant to today's discussion, he is a man who led the team of investigators that conducted the national survey on the extent and pattern of substance use. And the findings of this survey were published as a report we all more familiarly know as the magnitude of substance use in India. And this report has been immensely significant, both at the national level, as well as internationally. We are really fortunate to have Dr. Atul here with us to take us through a closer look at what the data is telling us about the issues and trends that have been identified through this survey specific to Nagaland. So Dr. Atul, over to you.
Thank you very much, Sushi. At the outset, I'll begin by expressing my sincere gratitude to my very dear and old friend Abu, the entire team of Kripa Nagaland, as well as all the other colleagues, many of the familiar faces who I see today. Thank you very much for giving me this opportunity. And I thought that I will begin by setting a kind of context of the entire discussion by providing some of the highlights from the National Survey report about Nagaland through a PowerPoint presentation. So if you'll allow me, I'll very quickly walk you through just a few slides to show you the drug use situation in Nagaland. Are my slides visible to everyone, Tushi?
Yes.
Yes, yes.
Thank you.
So let's proceed then. So what basically we need to realize is that our state, Nagaland, has a very rich and long history. There have been issues, there have been problems, there have been disturbances which the state has been dealing with for a very long time. The state itself has a very rich cultural heritage and diversity within the state. And as a whole, the state brings about and adds to the rich diversity of the India as a nation, as a country. So that's how that's the unique cultural aspect of Nagaland. Also, being in the Northeast and for various other reasons, the state has been grappling with a number of developmental challenges. And drug use is just one of them. We need to also understand this, that as a society, there are a lot of other things, lot of other priorities. There are a lot of other problems which are vying for the attention from the government, from the civil society. Drug use remains one of the major ones of them. Also, fortunately or unfortunately, the very unique location of Nagaland, being at the border, being at the known heroin trafficking route, has traditionally made it vulnerable for drug trafficking and drug consumption. Also, but what we need to understand is, and Chief Secretary Saab also alluded to this in his opening remarks, that in the context of drug use, Nagaland is not only seen as just as a state with drug problems, but also with solutions. In fact, Nagaland is a pioneer in the, I would say, in the country, in the area of community-led, peer-led, civil society-led response to drug problems. So Nagaland must be looked up to by the entire country as a state which can provide very unique, very contextual solutions to drug problems as well. But drug problems themselves keep changing. It's a dynamic issue, and hence we need to redefine our strategies to deal with these problems as well. Having said that, I will quickly go through some of the findings of the national survey. As we know that this was a large-scale exercise and first time conducted in all the states of the country simultaneously. So that's how now we are able to compare one state with another, as well as one state as against the national average. So that's what we will do today. We will compare the drug use situation of Nagaland with that of country as a whole. So as far as alcohol is concerned, Nagaland funnily happens to be a state with officially an alcohol prohibition. And whenever I discuss informally issue of alcohol availability in Nagaland with some of my Naga friends, they all just laugh or give a wide grin, implying that perhaps prohibition is more of a joke. And I'm sure it's not just speaking in jest, but the findings of this survey showed us that certainly at least the people who admitted consumption of alcohol through a household survey, in those terms, the alcohol use prevalence appears to be in Nagaland appears to be lower than that of the national average. Though I am told that these figures may not be very reliable, these figures were from the household survey, and household survey is fraught with the issue of underreporting, particularly when you are reporting about a substance or drug which is not socially very well acceptable, which is supposed to be prohibited or illegal, and hence perhaps the figure for alcohol that we see in Nagaland as compared to India being low may not be completely true. That's what many of my Naga friends tell me. I'll be happy to get more opinion on this from the August gathering here today. But what we need to realize is also need to see what is it that people are consuming. What we found in this survey is even in the alcohol prohibition states, majority of the people are actually what they are drinking is not illicitly made liquor. They are made legally produced alcohol, but which is illegally obtained. So it's a perfectly legal bottle of whiskey or rum which is bottled and marketed for some other state, but which is being sold and marketed and consumed in the prohibition state. And as we can see here from Nagaland figure also, more than 80% of people who report using alcohol in Nagaland, they use one of these legally produced alcohol. So in other words, alcohol availability, the legally produced alcohol availability does not appear to be one of the major issues in Nagaland. And there is a catch in this. It's actually a good news in disguise, because since the legally produced alcohol is available, we do not see much of the illicit alcohol or hooch tragedies, which can be really dangerous, fatal for public health. So whatever other negative consequences of excessive alcohol consumption, at least our population has access to safely bottled and marketed alcohol. That's what one can see. One can say looking at this data. Coming to other kinds of substances, cannabis, charas or ganja. Now, Nagaland is not one of those states where there has been a culturally accepted use of bhang for religious reasons. In many of the North Indian Hindi heartland type of states, bhang use is accepted. In fact, it's legal. There are legal shops of bhang available in many states of the country. Nagaland is not one of them. But still, the prevalence of cannabis use in Nagaland is much higher than rest of the country. And this is predominantly on account of charas or ganja use, not on account of bhang use. Also, next we come to the major class of substance, which is a problem issue for particularly northeastern states. That's opioids. In this survey we looked at heroin, pharmaceutical opioids, as well as opium, all three separately. All three as a combined fall under the category of opioids. And here we can see the huge high amount of prevalence in Nagaland as compared to the national average. In India, in the general population of 10 to 75 years, just about 2% people are current users of opioids. In Nagaland, every 1 in 4 individuals has used at least once an opioid substance in last 12 months. So that's a huge problem that we are dealing with. Since the population of Nagaland as a state is modest, is small, that's why in terms of absolute numbers, we do not see a huge number of people affected by opioid use problems. So, for instance, even 1% of UP would be more than 10% of Nagaland, right? Because of its sheer size. That's why the maximum number of opioid dependent people may be in other states, Punjab or UP, etc. But in terms of proportion of people affected, it's really the northeastern states like Nagaland. And in fact, the reasons behind this are very simple, very straightforward. In this map of India, we plotted the rank of states in terms of what percentage of their population is affected by opioid use disorder. And as we can see here, the top states from 1 to 9 are actually those states which are at the traditional heroin trafficking routes, be it from the northeast or from northwest. So many people in India, in fact, blame inadvertently the opium cultivation in some states, the legal opium cultivation in some states for opioid epidemic in India. Their rank, if we see the states like Rajasthan, MP or UP, their rank is actually among lowest in the country. So actually our opioid problem is dominated by heroin, and this heroin is largely that heroin which is coming from across the border. So that's something which we suspected, but the survey findings has made this abundantly clear. Another important issue is that in many states of the country, majority of, or if not majority, at least a large number of people who use opioid drugs, they use these drugs by injecting route. And this is something which has totally made the National AIDS Control Program's estimates go haywire. Till now, the standard number of people who inject drugs in India, with which all of us have been working and repeating it everywhere, is 200,000, 2 lakh people, right? And this number has been repeated for more than 15 years now, without realizing that what was the methodology with this number was collected, whether it needs to be updated or not. That's why in this survey, when we estimated that it's more than 8.5 lakhs people in India who are currently people who inject drugs, who fall under the category of people who inject drugs or IDU as per our NACO. And Nagaland finds itself here, despite being a small state, among the top 10 states in terms of number of people who inject drugs. So Nagaland is at 10th spot among the top 10 states in the country in terms of these numbers. And that we always knew that people who inject drugs as well as the associated issues of HIV, HCV are a known issue in our state. So this was about the major drugs. In sedatives also, as we can see, there is higher prevalence of sedative use in Nagaland as compared to rest of the country. There are other minor drugs like cocaine or ATS. Here one doesn't see much difference because still I believe very small proportion of people are using these substances like cocaine or ATS. I will be particularly interested in knowing from the colleagues in Nagaland here today about whether a pattern is changing, whether ATS is now making inroads in northeastern states, Manipur or Nagaland. And this is something we have been hearing for a long time. I believe that a kind of study is also being planned in some northeastern states to look at the prevalence of, or at least the profile of people who use ATS. And this is something which needs to make all of us worry. Why? Because this is not traditionally our substance of use. We don't know how to use it. We don't know how to deal with its effects. We don't know how to treat someone who is affected by these drugs. So that's something we need to keep a close watch on. Very quickly, we all know about the drug market, its balance about demand and supply, and the strategy to deal with drug problems in terms of demand reduction, supply reduction, and harm reduction. All of us are informed. I don't need to repeat all the need of balance with these strategies here. What I need to highlight is the limited effectiveness of our drug supply control strategies. very often our government is fond of saying that India is predominantly not a market for heroin. We are a transit country. Heroin just passes through India, and many people just start using heroin in India on account of that. But we need to look at how much of heroin is seized in India. When we estimated, looking at the official government figures, all supply control agencies jointly catch just about 18,000 kilograms of heroin every year. And if we try to calculate how much of heroin is consumed in India by people who are dependent, it's 360,000, which means it's just about 5% of heroin which is being consumed in India is being seized, is being caught off. Even if we make our supply control efforts double in size, it will still be just 10%. Even if we increase the workforce to 4 times and make it much more stringent, it will still be just 20%. So relying on just supply control strategies is not going to be the solution, which is going to be one of the major advocacy planks for us as civil society people, as demand reduction people. One of the also this problem, why this problem of heroin epidemic is rising, because of excessive emphasis on supply reduction, and even this supply reduction efforts, they are also diluted because we are dealing with just catching hold of 2 kg of opium here, आधा kilo charas there, 100 tablets of diazepam and celebrating it. So if all our supply control spreads are efforts are spread so thin, that means we are not able to do a focused work for international drug trafficking, which is occurring at such a large scale. So that's something, a lesson for our drug supply control agencies as well. And this is something we need to take up with them whenever we find an opportunity. Coming finally to our recommendation, our first recommendation has been that drug use is fine. What we need to worry about is drug use disorder. People who are affected by drug use problems or addiction, they need help, they need treatment, and that should be our one of the major priorities. This survey has again displayed a wide treatment gap. Ministry of Social Justice, Ministry of Health, they have some programs in terms of IRCAs or de-addiction. There are hardly any reach of these programs in terms of being on the ground. Just about 1 in 20 people who are drug dependent report having received any kind of help in their lives. Which means they simply we are not reaching with this kind of model for people in need. And hence, we need to move the focus, which is totally on de-addiction centers or rehab centers, inpatient residential facilities. We need to move out this focus to more community-based outpatient type of treatment services. So more clinics rather than centers is what we think about. The OST, the NACO's OST program, has been super hit everywhere, right? It's been super hit because it's a clinic-based approach. It doesn't require people to get admitted to a facility for 3 months and remain clean throughout their life. That's not what addiction treatment is all about. And hence, we need a massive capacity building investments there. I'm happy that in Nagaland also, there is some progress made in terms of drug treatment clinics. Dr. Bernice is here. We may hear about it from her as well. We also recommend availability of large-scale prevention programs, which are not just awareness. We all know in the name of prevention, what people like to do is just rallies and posters and banners for increasing awareness among youth. Awareness is fine. It's not enough to prevent drug use. What we need is skills in our young people to protect them from using drugs. If at all we need awareness, awareness needs to be about reducing the stigma, reducing the discrimination, making people aware that drug use disorders are also diseases for which help and treatment is available. They are not just sins, they are not just crimes, they are not just moral deviations. So that kind of awareness is much more important rather than just say no to drugs. We also need better laws and policies, and here particularly, rather than one of the aspects I already talked about, the ineffectiveness of our supply control approaches. Another thing which we need to talk about is why should people who use drugs be subjected to criminal justice system? they belong to health and welfare settings and not in criminal justice settings. We need to actually start now talking about the harms of criminalization itself, right? There is enough work which we have done in terms of harm reduction for people who inject drugs and hence give them safe safe needles and syringes. We also need to talk about harms caused by this criminalization of drug use and those legal reforms as one of the harm reduction strategies. So this is something, it's right time we need to start talking about. And this is related to the next recommendation about harm reduction. I believe in this country, so far, by and large, harm reduction has done a great job in terms of working for people who inject drugs, helping them protect from HIV, HCV, and other kinds of problems and issues. But still, we need to now understand and explain to others that the scope of harm reduction is far wider rather than just preventing HIV or HCV. Scope of harm reduction applies to all forms of substances. And hence, this should become a kind of ideology. This should become the lens by which we see substance use and related problems, not just the narrow definition of injecting drug use. And here I believe the civil society's role becomes very important. Nagaland, I'm very happy and I have been fortunate to know and work with a lot of civil society members as a very vibrant group. But we also need to remember, not just Nagaland, but anywhere in the world, civil society is a very big, very broad umbrella term. Within it, there are various kinds of ideologies and thought processes. There are die-hard harm reductionists within civil society. There are also die-hard prohibitionists and abstinence-oriented people within the civil society. There are also people who think that drug use is a sin or a crime and people need to be locked up. We have seen such examples in our country. And there are also people who understand the right way, the human right framework with which to deal with drug use. So our one of the roles civil society is obviously can provide is a very effective service provider, act as a bridge between the communities and the state. And the state here means the authorities, the establishment. And the last role I think is the most important role for civil society, that is of advocacy, raising the voice of communities and bringing that voice to where it matters. So civil society need not be seen only as just peer-led intervention, having outreach workers or peer educators from among the community. Very good, very important role, but it goes beyond it. We need people from the community, people from the civil society at the table. And here I would like to repeat someone who I heard saying this. If you are not at the table, that means you are on the menu, right? So we need to be on the table, at the table. I'll end with this tweet by Kofi Annan, former UN Secretary General. I believe that drugs have destroyed many lives, but wrong government policies have destroyed many more. May all of us work together towards reforming some of these policies. Thank you very much, ladies and gentlemen.
Thank you so much, Dr. Atul. As usual, your presentation has been really, really informative and very enlightening. And thank you for so beautifully contextualizing what is there to the context of Nagaland. Thank you so much. I'm sure Ketho is one of the young rising stars in the field of activism, whether it's on drug use or harm reduction or TB, hepatitis C, all over Nagaland or in India or in global platforms. So he is here today to talk about the current issues that call for urgent action from the perspective of the community. So Ketho, if you could just tell us a little bit about the present trends in drug use or substance use, whether you are noticing any paradigm shifts and which require some new strategies, all right?
So I just have a couple of pictures to share to give a real sense about where the drugs that has been used in the past and is presently now. And picking up some lines from Dr. Atul's presentation, but also more relating to the feedbacks that I got from the people who are currently using drugs. And many of the photo critics I would like to give to friends from Kohima, friends from Dimapur, and Mon, as well as Tingsang. So I've been engaging trying to compile some of the pictures, but if at all pictures are not very 100% visible to all of you in terms of the clarity. I would beforehand want to apologize for that because these are straight from the field. From begin with, yeah, addiction history, of course, has not been very much properly documented in our state, but the pioneers of people who have uh, been into this habit informed that it was as early as the late 70s or 80s. That is where the addiction pick up in the state of Nagaland. And initially it was with, of course, the Fansidar, which is a codeine-based cough syrup, and that resulted in heroin, and following that, all these pharmaceutical drugs that I'm projecting right. Some of the drugs that were very commonly abused in terms of pharmaceutical drugs, but of course, alongside heroin was, of course, the king of all drugs. But because of the exorbitant price, because of the huge demand of heroin, the price also just shot up, and drug users on the streets were not able to afford it. So that gave birth to more pharmaceutical drugs to land up in the street market. So some of the blue capsules that you can see on my screen are, of course, the spasmoproxivin drug, which is an opioid-based drug, as has been mentioned by Dr. Atul. And that chocolate color is coffee color is the Parvenspas, which is like another component of the dextropropoxivin hydrochloride, which of course is another opioid group of drugs. The other blue is, of course, the Walajasic, which is on the left-hand corner. These are, and the red and black one is, of course, Lobain. So these are all basically the category of the opioid group of drug in the form of capsules. You might be imagining why there's an Irisex bottle and a syringe and there's a tablet also. So those tablet represents the benzodiazepams, and that Irisex is something which we are now considering as the gateway drugs. In the state of Nagaland, it progressed. So this became very commonly used, I should say, around mid-90s and continuing till 2004-5, until the time the OST was implemented way back 2006 by the DFID challenge, which of course Tushi was a big mentor to all of us also again. So that was the time when this drug train tend to change its form. So this is just a usual scene that I pick up from one of the field visits. Not deny the fact that drug use is still with us, despite having treatment programs in the form of IRCAs and detox centers and opioid substitution therapies and harm reduction being operational for almost, I believe, 18, 19 years of the NSCP phase from 2 to up till now 4 and transitioning to, I believe, phase 5 very soon. But this is something that we cannot deny. It's still a reality. And so again, of course, Dr. Atul mentioned about charas, ganja. So these are also been used before and even presently is being used. But I would say that in comparison to other pharmaceutical drugs or be it heroin, it is not much preferred by the people who are into this sort of habit. So mostly it's just used as a mixture to enhance the intake of his choice of drug. So marijuana is just like a drug supplement to enhance his euphoric feeling. So the poly drug use. And of course there was nitrosan, which was very famous, but again we're happy that nitrosan in the form of nitrazepam has not been heard very much. Even this ampoule bottle that I am showing you, and as well as this brown sugar. That's so. These are some of the drug that has actually resulted in a whole lot of problems as far as the person's individual life is concerned, and also in the larger society as well. So presently, this is becoming very prominent, and I would also want to make a mention to all of us to say that there are new drugs in the state, even as we speak today. So one drug that we can see on the left-hand side is top left-hand corner is the sunflower, which is another brand name, I believe, for heroin. And it's, I think, a very adulterated form of the heroin because I don't think it can be labeled as number 4. It doesn't undergo the purification form of number 1, number 2, number 3, and number 4. So since the adulteration in terms of its coloring also is like dark orange colored or slightly brownish color. So I think it has a lot of mixture in it. But since there hasn't been any sort of clinic or I should say laboratory test to determine the content of this, we are not sure what other ingredients or chemicals are in this. But for sure it is a heroin-based opioid drug, and also to say that it is mostly penetrating the state of Nagaland from the state of from the country of Myanmar, of course, passing through More, and from that the drug route I'm told that it is going to Assam, and then from back to some of the neighboring towns and villages of Assam. It's coming back to Dimapur, and from Dimapur it's been sent across to other districts. It can be via Longnak Junction to Mokchun, and it can be Namtola or Tijit to Mon district. But for the other district, of course, it's passing through from Dimapur to Kohima, and then it goes on to the other state. So now heroin is in this form. Heroin is not the white color that we know of. Heroin is a slightly orange or light brown color form of heroin, and the brand name for this has been labeled as sunflower. Of course, the middle one, I'm not sure whether the picture is very clear, but it's of course brown sugar. And interestingly, brown sugar at one point of time was dropping down. The usage of brown sugar was dropping down. But again, we're hearing the reports that since the past, on an average, I think 2 years back or so, and continuing till now, heroin is back. Heroin is back. And because of this lockdown and all this, sort of, obviously, is leading to a whole lot of crisis, even in procurement of essential commodities. So even the drug users are also facing a hard time in terms of the easy access and availability to all this sort of drugs. So I got the information just speaking to some of my colleagues to say that prior to the lockdown, it was almost like 3,000 rupees for a container packet. If my friends can relate to what I'm trying to say, we know that there's a Kaka Chinese container, right? That can be sold. I mean, that can be bought from the pawn shops. There's a Kaka Chinese where you have the lime and you can put the Kaka Chinese. So that container, that plastic container, that's what I'm trying to say. So that this amount of drug full of that container, it was costing approximately 3,000. But as a result of the lockdown, it has shot up to even 7,000-8,000. And if you are unlucky enough and you are able to get in contact with a peddler who is very cunning, he might extract even 9,000 for this. So it is increased triple the time. So of course, drug users are also undergoing a whole lot of economic crisis because of the increase of drug, the price of the drug. So of course, this presently, I mentioned that the codeine was since there, and I think it could start off the whole history of addiction in our state. But now the other form of codeine-based, codeine phosphate-based cough syrups are in different brand names, and it is still, it has never been out of the picture. It was continuing since those days, way back 70s, 80s, 90s, and early, and until now also. So, and in fact, I would say that the proportion of young people, and the people who are already in the chronic dependency stage are also into this habit. So I would say that this codeine phosphate-based cough syrups are becoming is very common, and still very common. And like I said, benzodiazepams and all those nitrazepams were not much heard of, but even this drug, this alprazolam now, this drug has picked up. Since Spasmoproxevan was, as I've mentioned, it is coming back again. We are hearing some of the reports being that it is present, especially we have heard from Tingsang, we have heard from Dimapur, but it is now in a different quality. That previous original Spasmoproxevan from Wockhardt company was a drug which is of course manufactured for oral consumption, but drug users mix it and inject it. But we have seen that this new version of Spasmoproxevan from, I believe, from neighboring village or town of Assam is very difficult to inject. So difficult to inject means we're happy in terms of HIV and viral hepatitis B, C, or syphilis transmission, but still also to say that this drug also is not, it is not very common, I should say, but still to say that it has not gone away. And opium is of course there since the Naga history, I should say, especially in districts like Mon and Tingsang. So one of the other concerns that I want to bring to all of us is about the use of yaba. Dr. Atul of course mentioned 8 years. So we are all on the same page to say that Yaba is, of course, from the amphetamine type stimulant group of drugs. So it's a stimulant. So stimulant has been reported. I wouldn't say that it is very much or significantly being used by all the drug users across all the state, but this availability is it's picking up, I should say. And this picture, those two red capsules are the blue white, the Yaba that I'm projecting. And this has been taken from one of the drug user who is from Dimapur. And I've also heard that this Yaba is available in Mon district, in Tungsang district, in Kohima, and of course in Dimapur. It's very likely that if it's available in Tungsang, it's going to even be available in Mokchun, because that is the route of transit for any commuters as well. So that is how the drug also thinks. To conclude, these are some of the drugs which are being used, of course, and alcohol remains to be the father and mother of all drugs, even as we speak today. So with that, I bring into the end of my presentation to say that this is just a reiteration to put more weightage on the serious concern that we all should have as far as this kind of addressing this kind of drugs, as well as including the ATS group of drug is concerned. So yeah, happy to discuss further in the coming time. Yeah, thank you very much, Tushi, and everyone for your patient listening.
Thank you so much, Keto. As usual, that's a very, very comprehensive overview that you have provided us right from the field. Thank you for collecting all that information and enlightening us. And we hope that you will have some very, very significant recommendations to make as part of your closing remarks on what we can do to take these issues up in a very systematic, collective way. All right. Our next panelist is another very young lady, Sintina Iyer. She's a trained counselor, therapist, who has been providing counseling support across a wide range of issues through a chamber that she runs, associated with many issues related to women who use drugs and alcohol, as well as the spouses and partners of people who use drugs and alcohol. So we are very keen to hear from her some fresh perspectives about the specific vulnerabilities that confront this population and about the critical needs that need to be addressed from their well-being. So it's really good to have young professionals who are actually taking such an active interest in this sector. Over to Sintina, who will be talking to us about vulnerabilities faced by women who use drugs.
So hi everyone.
Hello.
It's good to be here. Thanks to Tushi for the introduction. I have been asked to talk about the specific vulnerabilities faced by women who use drugs. So, okay, I'm still new to this area and I'm not a professional when it comes to substance use, and I don't know a lot about drugs like the previous two presenters have shared. I'm still new, so I still have a lot to learn, but in my short interaction with women who use substance, I've come across certain issues and needs that they face. So I'll be looking at 4 issues: health, which I will deal with psychological as well as physical aspects when it comes to health. Then welfare of women, then violence, and also society, how they view women who use substance. So health-wise, on account of a lot of biological reasons, women get intoxicated and dependent on substance faster than men. So for example, in the case of alcohol, the onset of physical problem is faster in women, like cirrhosis of liver. So this is because women's body have a higher fat ratio than men's. Therefore, the alcohol becomes more concentrated in the female body, including the liver and even the brain. So females are more prone to osteoporosis, breakage of bones, and more likely to develop breast cancer, and also 5 times at a higher risk of death than men. As for women using nicotine, I've come across a few of them who use nicotine. So it is more difficult for women to stop smoking than it is for men, as that's because the craving for nicotine is linked to women's menstrual cycles, and they receive less partner support for quitting than men. So men are less supportive of women to quit. So specifically for women, smoking increases their likelihood of contracting cervical cancer as well as heart diseases, and especially when it is paired with oral contraceptives. And women or mothers who use substance when they are pregnant, we see that the use of nicotine has been linked to an increased rate of spontaneous abortions, prenatal mortality, premature births, low birth weight, and even behavioral problems in infants. So those are a lot of complications. I won't go into the detail. So when it comes to psychological health, addicted women are more likely to suffer from affect disorders like depression, anxiety, low self-esteem, and also 5 times more likely to commit suicide than the male counterpart. Also, women who are addicts have eating disorders and have a lot of issues with bulimia and anorexia and all those issues. And women using substance are also at a high risk of experiencing multiple problems that weaken their capacity to care for their children. So they will be either depressed or increased exposure to parental as well as partner pressure and violence and sexual abuse, psychiatric disorder. All this makes a woman, unable to take care of their children. So when we look at women and substance use from a societal perspective, women drugs users are considered irresponsible. And in a male-dominant society like ours, then in our Naga context, the role of women is seen as someone who nurtures, cares. The same applies for women, but however, when a woman is found to be straying from the societal expectations and standards set by the society, there is double stigma. So women face double stigma. So it is often misunderstood that women who drink and do drugs are either prostitutes or culturally oppressed and self-medicated. Oh, self-medicated, so something must be really wrong with this lady. And also they are often seen as, as if they don't have intelligence. There is a lack of intelligence. So only those women tend to use alcohol or drugs. That's what the society assumes. So the women are charged more harshly compared to men. So, and women entering treatment are less likely to have family support. Like I said, because of the stigma, even the families from, no matter what class or background they come from, the family is really ashamed of to say that someone in the family, especially a woman, is going through alcohol use. So they do not receive proper family support. No, and more likely, women have a lower economic status and less education and generally unemployed. When we look at the welfare of women, I want to look at pregnant women first here, because when a woman is pregnant and she is consuming alcohol, so the babies are likely to develop and at a higher risk of developing fetal alcohol syndrome. So that is the most preventable form of mental retardation in children, if we can educate the women and let them know that it's harmful, before it starts affecting the baby. So once a baby has this fetal alcohol syndrome, they suffer from a lot of developmental delays, behavioral problems, and facial and neurological abnormalities. So women with children also might hesitate to seek help. Why? Because of fear of investigation from social services, that they think that if they're drinking, the social service people will take away their children. So they have this fear, and also at times even deny necessary medical help. So a lack of childcare might be a barrier for women who are the sole or the primary parent in this case. So I want to look at the last issue here faced by women, which is violence. Researchers are becoming more aware of the dangers risk connection between addiction and violence against women. So the link appears to be bidirectional, which means women who experience violence are more likely to fall into substance abuse, and as well as women who use substance are likely to experience violence. So about 90% of women who use drugs and other dependency items are sexually abused at least once in their lifetime. And I've come across a lot of women who have been abused at least once, while 40 to 70% of alcoholic women have been victimized by sexual assault, incest, and rape, by sometimes even by their own families. So those are some of the issues that women are facing. So that's all I have for now. So we can discuss more later on.
Wow, thank you, Santina. Those are, you've thrown light on so many issues that we need to consider when we're planning programs and interventions for women who use drugs or alcohol. And yeah, thank you for bringing in your personal experiences there, which gives us a sense of how real the problem is. And the need for various different departments and constituencies to come together collectively to address these issues. Thank you, Santina. Thank you so much. All right, our next panelist here, Harshan, the Regional Director, Northeast of Kripa Foundation, Nagaland, Kohima. But he has also been representing the community of people who use drugs and vulnerable other key populations in several important national and international platforms.
Today, I'm very much privileged to have three mentors, so to say, in the panelists. The first goes to Ms. Nitsa, now in Jerusalem. She was my first counselor and a mentor on drug treatment, counseling, and HIV. And later on, Dr. Atul has become one of my mentors in harm reduction programs, especially in OST, oral substance therapy. And one is, of course, you, who I'm privileged to have three of you in this panel. Thank you very much, three of you. And as Tushi has given a privilege to share a bit on the impact of drug use. Out here, Dr. Atul has already clearly mentioned and has highlighted that drug use is not much of a problem, but drug dependency or drug use disorder is a problem. And when once become a drug use disorder or have dependency, then we get involved in so many things else. If we see those who are really drug dependent or who have drug disorder, use disorder, then the increase of crime occurred in our society, because we drug users, in order to support of our addiction, we committed lots of crime like cheating, manipulating, extortion, and so on. And because of this drug disorder, many of our peers, and because of the criminalization of the drug use under NDPS Act 1985, under Section 27, because of that, many are expelled from school, and many of our peers who use drugs, because when once become a dependent person or having this drug use disorder, our mind become a slow learner. So therefore, many of our drug use become a school dropout or college dropouts. And of course, in health issue, if you see, then it affects our physical, mental, and also not only that, because with this, because of the injecting drug use, HIV, viral hepatitis, TB, and so on, there are lots of complications happens. And the impacts is not just on health issues, but we can also clearly see that premature death because of drug overdose or health complication, drunk driving and accidents, and so on. And because of the drug dependency, the impact also give on it breaks the families. Divorce takes place, and many of the family members are left as a widow or orphans, and also have unhealthy relationship. domestic violence, frustration, depression, self-pity, resentment towards everyone, including God, and so on and so forth. And because of this drug dependency or drug use disorder, loss of working hours in office, and also productivity. And when we know that, when I say loss of working hours and productivity, uh, those who are dependent on drugs or alcohol, uh, the priority is on our drinking or using. So we neglect our work in office or in our own domestic at work at home also. It also affects our economy. Uh, because because of our drug use, and we all know that the drugs itself is not manufactured in Nagaland per se, or we don't cultivate. Therefore, because of our drug you to buy, lots of sales out our financial system. So in case if we have uh, 50,000 drug users and alcoholics who use alcohol, if we have 50,000, for example, and if they spend 100 rupees per day, then it's come up to 50 lakhs in a month. And in a year, it comes to 15 crores. In annually, we'll be spending around 180 crores. So we are spending lots of financial resources because foreign made liquors, which Dr. Atul also have shared in his presentation, or the presentation of Keto, which has highlighted about heroin or sunflowers or world is yours or pharmaceutical drug, those who are not manufactured in Nagaland. Therefore, all our resources goes outside the state. So it affects our economy. Not only that, after spending lots of resources in our using and drinking, we need, because of the side effect, as I said earlier, we need to go for treatment to, again, hospitals, and we need to pay doctor consultation fee, and also we need to buy vitamins, antibiotic, and so on. So therefore, again, we need to spend lots of resources for our treatment. So the impact is very huge. So therefore, we need to uh, make a priority as to help those who use drugs and has become dependent on drug use. And we also have to look into not only look into the NDPS Act Section 27, which penalize for drug use or trafficking. But it's high time that Dr. Atul has mentioned in his presentation that we need to decriminalize drug use. Therefore, even in the NDPS Act, in section 64A, it provides decriminalization, it provides immunity to those drug use who are willing to go for drug treatment. So we have to capitalize on section 64A and look into the immunity, or for those who are wanted to go for OST treatment, we have to also capitalize on NDPS Act Amendment 2014,
Right.
Section 71. So therefore, the law allows us to avail those facilities, and the fundamental and also our fundamental rights also provide rights to health is always there. But we are only looking at Section 27, which criminalize the drug use. There is where the problems goes. So yes, as I said, the impact is very huge because it's increased crime. Provides lots of school and college dropouts. It provides health complication, premature death, and it breaks the family, and also it affects our economy. Therefore, now it's high time, as our Chief Secretary in his own opening remarks, that we have our substance use and abuse prevention and treatment policy 2016. So we have to capitalize on that. But out there, the policy is not that vast. So we need to amend our drug policy in order to help people who use drugs and to tackle the impact of drug use in Nagaland. Thank you.
Correct. Thank you. Thank you. Thank you so much, Abu. Let us all make note of these issues that you have actually been working on over the years, and some of them are coming to fruition. And thank you for enlightening the larger group on these issues that we need to be focusing on. All right, our next panelist, Ms. Nitze Meyer. Nitze would actually prefer to be very modestly introduced simply as a former CRIPA staff who has years of experience of working in drug use related sectors in India, Myanmar, and Nepal. But we know that this would be hugely inadequate. Over the years, Nitze has made immense contributions, as Abu was saying, to the HIV sector, particularly in Nagaland, in various capacities. And she has been deeply committed to the cause of PLHIV and people who use drugs, among other vulnerable populations, since the very early years of the response to HIV and drug use in Nagaland. Nitze has worked across a wide range of sectors and geographies in various capacities, and now she's based in Jerusalem in Israel. We really look forward to hearing from Nitze, particularly on lessons we can learn from global experiences that we can adapt to our context. So Nitze, over to you on talking about, on addressing how we can talk about vulnerable populations. Yes, welcome.
Thank you.
Shalom.
Shalom, shalom. Our previous speakers have touched on so many important elements of our discussion, so I feel like I'm just going to be repeating some of what they were saying. But I wanted to stay focused on the issue of how drug use affects families and how families enables drug use in our society. Much of my work, as you mentioned, is in our region. I was with CRIPA in the 90s, and then I came back again in 2002 until 2008. And then from 2008 to 2012, I was in Myanmar. And in Myanmar, I worked mainly in China-Myanmar border, Kachin area, and Thailand-Myanmar border, which is mostly in Shan State. So the context in which my talk is based is mainly our region. But I have seen over the years that our region has specific issues, but not unique in any way. Anywhere in the world where there is high use of drugs, there is the elements that enables that is almost the same. And I think we can take comfort in that. And from my experience, I have seen that anywhere where there is conflict and civil unrest, the first victim of conflict and civil unrest is the family unit. And when the family unit is because of separation, because of trauma, because of despair, dislocation, displacements of populations, all this lead to the breakdown of the family unit. And when there is a breakdown in family unit, any individual becomes very vulnerable to any challenge, and drug use, of course, is a major challenge. And then coupled with that, we have the issue of accessibility, and we have seen how accessible we are to drugs of any choice. Whatever drugs of your choice is, you have an accessibility to that. And that adds on to the problem. We have seen very clearly from Dr. Atul's presentation and also from what Abu told us just now and Ketho mentioned. And then, of course, when there is conflict and civil unrest and accessibility, you also have the element of survival. You learn survival skills. And when you are in a family where there is no parenting support and where there is some kind of a dysfunctional lifestyle, say a parent themselves, he or herself, is a drug user or a victim of trauma, then you see that there is a child develop certain behaviors, and those behaviors are their survival tactics, like cheating, stealing, lying, pretending everything is okay, denying, escaping from reality, and all this sort of behavioral issues becomes a norm. it becomes, it's validated, first of all, in their own family. The parents say to them that it's okay to lie, it's okay to cheat, it's okay to pretend, it's okay to deny, it's okay to escape your reality and pretend everything is okay. And of course, when you have this, it's very hard work. I mean, you cannot keep up with this kind of behavior in a normal situation. You need to find a way to make it normal. And then when you get access to drugs or you are exposed to drugs, you suddenly realize that there's something else from the external that helps you maintain that lifestyle, that maintains that behavior. Now, we all know that behaviors are not, you are not born with a certain behavior. Behaviors are learned in the environment that you grow up in. And as I said, the first environment that where you develop these behaviors comes from your home. And then the society has a major part in this. And of course, we all know that the initial entry to drug use, any drug use, begins with some kind of curiosity and some peer pressure. And we don't have scarcity of that in Nagaland. The peer pressure issue, we know that there is an abundance of that. And then, of course, once you get into the entry point, then you realize that this external force or external support helps you maintain the certain behavior that you were struggling to keep. You sort of develop your own network of support system that helps you stay into that. And then you have a society where there's a lot of, and Abu mentioned this earlier, there's a lot of shaming and condemning, and so nobody wants to be the first to admit that there is a problem here. Nobody wants to be the one to say, we have a problem. So the problem is pushed under the carpet, is denied, and then you move on to the stage of where we call drug use becomes a disorder. I've also seen that the critical element in this stage is the importance of intervention at the entry stage. And the entry stage, we know, is the community support and institutional support. And we see that young people anyway are always curious. The young people anyway are driven by what their peers are doing and what their friends are doing. And when you are in a situation where you don't have positive life skills guidance or life skills development avenues, so or a career guidance in institutions, in schools or in communities, you go astray naturally. And I feel that the first intervention, I'm adding on to also the suggestion, I think here, that the first critical element in any intervention is the intervention at the early stage. There's a saying that if a family cannot look after their children, it's the responsibility of the community to look after the children, because their children are the future of the community. So at the community level, what do we do to intervene in that stage of, in that early stage? I think is something that I would like to ask to think about. My work with CRIPA from 1992 to 1998 and 2008 to 2002 to 2008, all these years has been primarily focused on the impact of alcohol use on children or drug use on children. And I've had the privilege of working with many children in Nagaland and Bombay and places where I have had the privilege to work. And I see that the only way we can prevent, or the only way we can minimize the impact of drug use in an individual life and in a family is to work with the family as a whole. You cannot treat a user in isolation without helping the family to heal. I think, and helping the family to heal requires a lot of efforts. I'm so glad that we have counselors who are working with the women, the mothers, and I'm sure you have counselors and staff in CRIPA and elsewhere working with children affected by alcohol or drugs or HIV, and also not necessarily children who comes from alcohol use or drug use families, but they are children who are orphaned by our conflict, or children who are in some form of dysfunctional homes. And I think that intervention, the work with children begins with building on their confidence and their self-esteem. And with this, I really enjoyed working with our children there. That those who have been given a support system, that they are special, they're unique, they are cared for, and that they can choose to take a new path and a different path. And then they know that they are not alone in that journey, that there are people around them securing them and protecting them and supporting them in that. So that creating that safe environment, the network of the safety network, as we call it, creating a safety network where it is okay to talk about your concerns and your difficulties. It's okay to talk about your family situation. It's okay to talk about your struggles with drugs, if any. I'm hoping that you're already dealing with children before they were exposed to drugs, but if at all they're already exposed to drugs, that it is okay to talk about it and to deal with it. I think all this helps in eventually reducing the number of people getting to drugs in the first place, and even then, even after they are into drugs already, to preventing them from developing a disorder, drug use disorder. And so my conclusion then and now is always that drug use is a family problem. We need to deal with the family. We need to deal with the root cause of dysfunctional homes, the behaviors that are validated in the dysfunctional homes, and we need to journey with them, find them, that they need to, the whole family needs to find healing and a support system, and it is our responsibility as the community to create that safety net for them to survive.
Thank you, Nitsa. Thank you for bringing in those very realistic angles. Yes, we will introduce the next young lady, Dr. Bernice Zavitsa, Joint Director of Targeted Interventions under Nagaland State AIDS Control Society. Bernice has been working for more than a decade officially in this position, and even more before this, I think, before she officially joined. So she is familiar with all angles of the whole response to HIV and drug use. So we look forward to hearing from you, Bernice, on the key elements in the current program for people who use drugs or inject drugs, in particular in your context, in Nagaland, and some of the impacts, and perhaps an indication of what changes we can look forward to in the new phase of the national program. So Bernice, over to you.
Okay, thank you, Tushi, and thank you to the CRIPA team for facilitating such an important discussion. I think it's always better late than never. And I think I'm sure that with the help of the CRIPA team, we'll be able to take forward these discussions and concerns to far higher levels. So, as far as my point of the discussion is concerned, I'll be limiting myself very closely to the small program that we are implementing as part of an HIV/AIDS intervention program for drug users. So we cater to a small population of the large group of people that we have been talking about since the first presentation given by Dr. Atul Ambekar, showing the magnitude of the problem at the national and state level. But my focus will be very specific to the HIV intervention for injecting drug users in the state. So over the years, like we have also seen that harm reduction approach, as Dr. Atul Ambekar rightly highlighted also in his presentation, had worked well in terms of reducing the harm of an injecting drug users getting the HIV infection. So I think those are some of the positive impact that we see in terms of HIV program. And whilst reaching out to the small population of the injecting drug users, or let's say injecting drug users constitute a very small population of the large substance use population that we have. So through these very small populations that we closely work with, we also see that injecting drug use doesn't happen overnight. And it's important for us to understand that we have, this is a concern that we cannot just, leave aside and not talk about. And we are very happy that there are official documents highlighting the magnitude of the problem in the states. And through program data, we have also seen that the problem is there, and an individual never becomes an injectors overnight. They pass through a whole journey of, initiating into other oral drug use and then finally getting into injection. So at present, our harm reduction approaches, we look at creating that enabling environment. We are not saying that drug use is bad. We are not saying that you should not use drug, but we say that we follow the harm reduction approach, saying that looking at reducing harm in the process of being into injection. So our approach is basically creating a very enabling environment. And we also have the strength of the community. The strength of our program is reaching out to the other communities through their own peers. So it's a community-led, a peer-led intervention program, which we really, which is the strength of our program implementation. We look at, for others, for few who may not be familiar, but I see in the participants, I think most of us are familiar with this concept of harm reduction, so I may not elaborate much on that. We also ensure like clean needle syringe, and then we also have this opiate substitution program, which came in as a package of harm reduction. So this opiate substitution program, as we see, like in absence of a very, extensive treatment facilities, drug treatment facilities in the state, we are also seeing that the opiate substitution program is helping a lot of those who are really in need. And we also get, recommendations to reach out to a larger number of populations. And we are very happy that the community, the administrators, the government, and even the police, they have recognized the strength, the effectiveness of the opiate substitution program for people who needs the support or the treatment. So I think those are something that have come in, and then through our support, we have a team of young people, which our CS had also mentioned in his opening remarks in MON. It's pure, out of need that a group of young people started try to find out solutions to address drug abuse in the area, especially in the Indo-Myanmar belt. And that's where, because our program is very limited at present, but with the technical experiences that we had, we coordinated and they were able to provide support for oral drug users in that belt. And we also see a very good impact. There are lots of people who had come out of their drug, who are in recovery and who are very productive and active contributors in the society also. And we also, here in our state, as we all are aware that our community members we have a very vibrant and active community members with us. And they are always our strength, because they are our eyes and ears in the ground, and they also, they are the foot soldiers themselves. And then they've been a big asset as far as our program is concerned. They've always been an asset, and we really depend on the community participation and support in making our implementation successful and trying to understand the challenges that the community faces, and we work on our strategy wherever possible. So we are very thankful to have a vibrant community member. We have Abu, Keto, all of them are a big supporter of our interventions in the state. Changes. We are looking forward to a massive mapping exercise this year. And we had our orientation virtually, and we are planning to have the community consultations and other meetings. But we are, and then we need to do the training of our field team. So these are few steps that we thought we should be able to do during this situations where mobility is highly restricted at present. However, like we are looking forward to this mapping exercises, because this is going to be, we are looking at covering all the populations and nooks and corners of Nagaland. The villages, the areas where the current intervention is not reaching out are going to be listed out. And then there'll be team doing assessment in those places to actually estimate the number of injecting drug users and other vulnerable populations in the state. So that's an exercise that we are really looking forward to. And in the magnitude of substance abuse study, it was presented that there are about 34,000 injecting drug users. However, at present, our program, we have been able to reach out to about 19,000 currently. So we are looking forward to try and understand through this mapping exercise. It might be able to actually bring out some populations that we may have been leaving out unintentionally. Okay. And then, so we are really looking forward to this estimation, to this programmatic size estimation, population estimation exercise that is nationally. So we'll be part of that. Hopefully, like the result of this study will be able to, the objective is that to use the result of this study for programmatic planning and re-strategizing the implementation plans if there's any. However, those could be, based on that study, we might see some changes coming in the next phases, because there's an extensive study that's going to take place. Mm-hmm. Nevertheless, we are continuing to implement innovations, things that the state feels is important. We are continuing to do it in a pilot basis, however small it may be. We are trying to try out, along with our NGO partners, the community leaders. Along with them, we are trying to see how this, how the small pilots that we do, for example, even the overdose management that was community initiated, the N-Nagadao, the Nagaland Users Network, there was a discussion that is very important that post-COVID, there could be a situation of more overdose cases, and for which we might need to have a quick orientation. And likewise, it's that coordination, we were able to do the overdose management virtual training also. During this COVID situation, we have also experienced the challenges, but we are very happy that we have a very supportive community, plus even the village councils who are very supportive of the OST program. And the village councils in many places, they themselves organize amongst themselves, depute one person to come to our center and get the doses of people who are on OST and take it back to their villages. And that coordination was really very overwhelming. And we're very happy that people are aware of the positive impact and the benefit of the programs that we are currently implementing. Likewise, even in the border areas, border means, again, this is to do with the interstate border, the Assam border. We had also had suggestions and requests coming from the district administrations, the community, the health authorities, and we opened dispensing windows with their help. So we had opened 2 dispensing windows during this COVID situations also. So likewise, if we have to see a little bit of data, during this COVID situation, we had an increase of 20% registration within this 2-3 months. So we do have the population who really need. We have people who really need the services, and we cannot keep denying the fact that drug use or substance abuse is not here in our state. We cannot keep denying the fact that we do not have those problems. The state doesn't face those problems. So we need to continue our discussion, advocacy, sensitization, and awareness on this subject. One is, it is also very important for all of us to also identify that, like the instances which NITSA has raised, discussed regarding the importance of family, regarding the importance of prevention, demand reduction, you know. So that is a very important area, that critical area that we need to look into. Ultimately, treatment for those who are in need should be in place. And then the primary prevention activities, initiative, more awareness has to be, we need to strengthen those areas. And then I think when we talk with any, be it the government, be it any civil societies, when we talk to them, people are willing to come in. People actually need awareness. They want to enhance, once their sensitization on the issue, or once their knowledge increases in terms of understanding drug use or substance use as a disease, then they are more, you know, concerned, and we feel that they are also more proactive. So I think it is all very important for people who have been dealing in this, especially with like organizations like KRIPA and Nagadao, the ARC Foundation, and all those, to come forward. And then we need to have those kind of advocacy also. The policymakers, I think this level, this kind of understanding has to be disseminated up till the policy levels, so that they are able to actually understand what we are trying to explain, what we are trying to say. And I'm sure like the response would be much more bigger, larger, if we're able to actually, you know, have a kind of a sensitization or an awareness with the people who would matter in terms of putting you know, policies in place. So that is one thing that we just want to discuss. If there are any, I'll be happy to take the questions later. Thank you.
Thank you, Bernice. Thank you for the very clear picture of what's happening and what to look forward to. And thank you for also bringing in like these important findings during the time of COVID. We'll quickly move on to our final panelist, Mr. Wango Langsim, who's a nodal officer on drugs in the Department of Social Welfare, Government of Nagaland, and also a co-host of this panel discussion. So Mr. Langsim, may I request you to provide a quick overview of the priority issues and programs related to substance use in your department, or that your department is concerned with?
Okay, thank you. It is my pleasure to be a part of this panel discussion. I think I'm the last panelist and also the least experienced panelist in this field. While planning for this program, I really wanted my commissioner and secretary to be a part of this program, to be a part of this panel discussion. But due to other equally important official engagement, she could not be here. She could not join us today. Anyway, we have good wishes from her and also the Director of Social Welfare. Well, when I joined the Directorate last year, one of the assignments given to me was Nodal Officer for Drug. And I thought I will not have much work to do in this issue. But after I attended a meeting in the Ministry of Social Justice and Empowerment, I realized that the department has huge responsibilities. And accordingly, after I came back, we prepared action plan for 2019-20. And we were expecting to start a program by the beginning of this financial year. But then unexpectedly, this COVID-19 pandemic has, you know, disrupted our plan, and we could not do so as desired. Organize few virtual programs in collaboration with the KRIPA Foundation and ARC Foundation. And I would like to thank the Kripa Foundation and the ARC Foundation on behalf of the Social Welfare Department for all the helps and assistance rendered to us. As pointed by Chief Secretary this morning in his opening remark, we do have Nagaland State Substance Abuse Prevention and Treatment Policy 2016. But the department feels that in order to have any effect, in order to implement any schemes or any programs effectively, we need to have effective policy. And with due respect to those who were involved in drafting this, the first Substance Abuse Prevention and Treatment Policy 2016, we feel that it needs to be amended to make it more effective. And accordingly, after obtaining due approval from the government, the department is already on the job in drafting the, amending the or reviewing the existing state policy. And once we are expecting it to be done before 15th of August, once it is done, we will share with you for necessary inputs before putting up to the government. We have collaborated with the Kripa Foundation in arranging or in producing a few radio jingles and then animated videos, because we feel that young people can be reached through this, social media. Especially these days, social media is widely used, and then I think we can really penetrate through this. So we have, as mentioned earlier, we have organized few programs, and we are already working on many other programs that will be coming up. And then we also have organized few virtual programs in collaboration with ARC Foundation, targeting youth and students. And many more programs are in the pipeline. The department has also launched helpline numbers, 2 helpline numbers in fact, because we feel that especially during this pandemic, is recovering addicts in different parts of Nagaland. They'll be going through a lot of different difficulties. So if anybody needs counseling, they can dial the given number. So we are collaborating with Kripa Foundation and then Vertical Homes in running these helpline numbers. We also have we are also organizing home-based detoxification program in Mon District in collaboration with Evergreen Society. And once that is successful, I think we are planning to have such program, more of such program. So we are waiting for the response and also the report from the organizers. We also have supported few community detoxification camps organized in Mon. And then in collaboration with Kripa Foundation, we were planning to organize in this Pandari division also, but due to this pandemic, we are not able to do that. That is on hold now. And then we are also in collaboration, we are also talking with ARC Foundation to organize somewhere in Seminyu area. So far, we are, the department, as I've mentioned earlier, what we used to do was, if any proposal comes from the NGOs, we used to recommend that proposal early. But with this drug demand reduction program, the department is also, have a lot of responsibilities. But led by the director, we are all new incumbents in the director. And even myself, I am learning a lot And especially when I have conversation with any conversation with Bentang from Kripa and then Keto from ARC Foundation, every conversation I learn through them.
Wonderful.
So I'm hopeful that together we will be able to really contribute something to our society. Once the policy is amended, I believe it will give us the clear guideline as to how in government level we have different departments and different departments will have different responsibilities. So how it will help us, enable us to work without overlapping, including the track demand reduction program. On 15th of August, Nasa Mukt Bharat campaign will be launched in 3 districts. And I think I'm hopeful that this campaign will enable or will help in mitigating the drug abuse to a great extent. Both Commissioner and Secretary and Director of Social Welfare are fully in support of any programs that aims at generating awareness for mitigation of drug abuse, for which I am also very grateful to them. And together, we can do so much. Thank you so much.
Thank you, Mr. Langsim. And I think we are really fortunate to have a dynamic officer like you who is so willing to work together and move together, take the community along, take the NGOs along with your programs. And it's a really optimistic future we look ahead to, with the Social Welfare Department in Nagaland being so open to listening to the voices of the community and collating inputs and willing to collaborate and work with so many other departments. Thank you so much. We have great expectations from you and your department, where we will request the panelists to take some time to very briefly flag the most important issues that you feel should go in as strong recommendations. So perhaps we'll start in sequence of appearance. We'll start with Dr. Atul. Dr. Atul, if you can just give 1 or 2. You have mentioned a lot of recommendations, very essential ones in your PowerPoints, but if you would like to flag some of those. Thank you.
Yeah, thank you very much once again for this opportunity. At the risk of repeating myself, I would once again reiterate that let us not be bogged down by the figures of number of people using drugs. Right. We need to be worried about number of people suffering from drug use disorder.
Yes.
They are the ones who need our immediate help and attention at this moment. You see, I mean, this question is often asked, what should be a bigger priority as far as public health and welfare are concerned? Drug prevention or drug treatment? People try to make this distinction, and there are many people who think that prevention is much better than cure, and hence more investment should go into prevention and so on. Well, the question I need to ask them is, if a corner of your house is in fire, you try to extinguish that fire, or do you start giving lecture to your kids not to play with fire? So the first thing needs to be to start helping people at the urgently affected by drug use disorders. And in this context, we need to have massive investment in making evidence-based friendly treatment available to people. And that treatment doesn't only mean a rehab center for 6 to 12 months admission. It may mean a range of services, including outpatient treatment services, clinics, OST type of services, not just for people who inject drugs, but even for people who do not inject, but use drugs by other routes, including for alcohol use disorder patients as well. So that should be our number one priority. Secondly, addressing the stigma in the society for drug use. That's very important, that people suffering from drug use disorders are just patients. They are not criminals or sinners. That I would see as the most important priority. And finally, advocacy with the law enforcement, that please do whatever you want to do to stop large-scale drug trafficking and peddling. But please spare people who use drugs. They need not be booked under any kind of criminal act. So these are, I think, 2 or 3 priority areas I think we should to move forward with.
Thank you so much. That makes perfect sense. Yes, Keto, please, your recommendations.
Yes, actually, too many foods on the menu. It's
Uh-huh.
time for us to sit on the table and have a lot of discussion. And therefore,
Yes.
yeah, I think I'm happy that Social Welfare Department also is very much now in the picture with all of us through a collaborative effort. We need to continue the dialogue. That is the first thing that I want to inform. Uh, Based on my presentation, of course, the ATS being another group of drug that is trying to gain its popularity. I, and I say this because many of our interventions and programs in terms of management and treatment are very opioid-based centric. So therefore, I think it will be good for us to have the ATS concentration level of prevention or in terms of even management also. That's the second point. The third is, of course, there are of course new people getting introduced into drugs, and those people are, I say, the group of young people, the young adolescents, and therefore not only about the primary prevention, I would say, an initial intervention for them who have been recently got introduced into once or occasional use. Why not we prevent? So we need to come up with some sign of some sort of initial interventions. That is something that I have on the table again. And the other thing is about having a robust mechanism. I think this all will be covered up once the 2016 drug policy is amended and it comes into the picture to bring a reflection of all this in terms of, because drug use is not only about prevention and treatment and management. I think it's about the follow-up care that we all need to be concerned about in order to reduce the relapse case and the chances of other repercussions of follow-up care of drug use. Therefore, what picking up from what Nietzsche has said, I think that word, the safety network, that becomes very relevant in what I'm trying to say just now. So the mainstreaming them back into the society is very important. I think there needs to be a bridge from the OST to the mainstream society, from the rehab centers or from the special care homes or the observation homes to the mainstream. So I think there should be a safety network. And I said that this could be possible if the drug policy could also have some sort of inclusion for setting up midway homes as a bridge from the post rehab and treatment course and being mainstream into the society. So very quick points. Thank you very much. Thank you, everyone.
We have this as the policy in 2016 has been launched, and the state government has already accepted to recognize use disorder as a disease. So therefore, in that line, I wanted to reiterate that what I have said in the earlier position, and Dr. Atul has also highlighted about to sensitize the law enforcement about the not to penalize drug users. So on that line, I just wanted to highlight that more capacity scale building and for the community, and also sensitization program for stakeholders, various stakeholders. We are dealing not just only the law enforcement agency, the uniformed personnel, but we also have stakeholders, village, panchayat, and so on. So therefore, capacity skill building for the community and sensitization workshop for all the stakeholders should be should be our priority. And also, as some of us has suggested, we also should have more consultation program or panel discussion on various thematic topic, not in one topic, so that that topic can be thoroughly covered. Thank you.
My suggestion is primary prevention should be integral part, should it be an integral part of any intervention or policy programming. And life skills development and career guidance for young people should, for young people is critical to keep them protected and to provide that safety net that they need. So even when they are exposed to risk of drug use, they are still able to move away from it as and when there is an awareness of its negative impact on their lives.
I would put up 3 recommendation points. One would be the need to identify substance use as a critical pathway to human resource development in the state. That's one. The second would be the need to strengthen our support for oral drug users and people dependent on other substance of abuse, like maybe alcohol. And the third would be strengthening our primary prevention education and awareness program and establishing treatment facilities for those who need it. So I think
I hope and pray that this COVID-19 pandemic ends as early as possible. Now, we should fight against drug abuse just the way we have fought or we are fighting against COVID-19 in terms of government's response from top to bottom, community participation, a contribution of individuals and faith-based organizations. Because our response to COVID-19 has been tremendous, and in some area, in some places, even beyond. And the same should be replicated in our fight against substance abuse.
So in conclusion, on behalf of People Foundation and the Department of Social Welfare, once again, I thank you all for your time, your participation, and most of all, for your patience. We are particularly grateful to our panelists for bringing in their valuable perspectives, and we really sincerely hope that we can collaborate more closely in the near future. And in closing, I'll just echo the words of our Chief Secretary in his keynote address to looking forward to collectively adopt a multi-pronged approach where all of us can work together in the future to address this issue. Thank you so much. Bye-bye.